Thank you, Dr. Jalal. And with that, we can start our cases. So I'll start with case 1, which is about immunotherapy and IBD management. So this is a 60-year-old gentleman with a history of left-sided ulcerative colitis who developed, unfortunately, metastatic melanoma. He was started on an immune checkpoint inhibitor. So just to start the story from the beginning, he was diagnosed back in the 90s, started on infliximab in 2008, and he has been in remission since then. In 2021, he was diagnosed with a right shoulder melanoma, underwent surgical resection. Did okay until May of 2022 when he developed metastatic melanoma and he was started on nivolumab therapy in June of 2022. Subsequent PET scan in July of 2022 showed progression of the metastases. At that time, there was a whole discussion with the patient, which included either adding ipilimumab to nivolumab, considering colectomy in anticipation of immune-related colitis exacerbation. So I want to stop here and just pose the question to the panel. And I think one of the striking things that got to me in this case is recommending a colectomy up front before adding a second immunotherapy. So what is your experience and
So it would be for combo immunotherapy, not
correct.
Just, okay.
Yes. So if it was for two reasons. It was one for the combo because of the risk of the ICI. The other reason that was posed for the patient is he was metastatic melanoma and unfortunately not responding. So the rate of response with combo was still low. So to be eligible for clinical trials, a colectomy could get him there. So that was another reason.
And I assume the patient is still on the infliximab, or was that discontinued?
He was still on the infliximab at that time, correct? Yes. And why do you ask that? What?
Why was he still on the infliximab?
Because of the UC, he was in remission.
Yeah. I mean, it's one that drugs I prefer my patients not to be on, but they have that
Great. For everyone who didn't.
Yes.
First and foremost.
Especially if they had been doing well.
Yes.
So I think that the combination of him maybe not being on infliximab and it might make a strong argument for colectomy.
Mm-hmm. Perfect. And Dr. Sacker, you had a question or a comment?
Ulcerative colitis has a worse outcome on a checkpoint inhibitor than somebody who doesn't have pre-existing colitis? After all, it's a different mechanism of colitis, presumably.
There is from Dave Valek's work shows that people with pre-existing UC have an increased risk of ICI colitis.
Ah, I didn't know that. Okay, thank you. I learned a lot.
But
it would be a tough sell for the patient.
A colectomy.
Yeah. Colectomy up front if he is in remission.
Mm-hmm.
One may suggest monitoring the patient, so getting him off the infliximab and doing routine calpros every 3 months and trying to monitor that way. I don't know.
And if you take him off infliximab, would you switch him to something else, or would you just watch him without anything?
Switch to Veto?
Yeah,
Switch to
something
Veto?
safer.
Yeah,
That's
I
what
mean,
I'm
I'd
hearing.
probably switch him before considering colectomy. I mean,
Yeah.
I don't think I would, say it's such a bad idea if, let's say, he couldn't tolerate a switch. Let's say he'd already failed other things and he wasn't responding, et cetera, et cetera. But
Then
it seems
you would consider.
Someone who's been in remission for years and never been tried on any other medication, it would be reasonable to put him on a less TNF-like medication for metastatic melanoma and see if he then tolerates the immunotherapy before going to colectomy.
Sorry, did you say there was a requirement for
For a
trial?
clinical trial, so
Yeah.
for clinical trials with metastatic melanoma, for immunotherapies,
Yes.
if they have IBD, they're not eligible because of the risk of ICI. So if he had a colectomy, he would be
He
eligible.
would not have, okay.
Yes. So that was a limiting factor for him. That was
So
something
then,
that was
yeah.
brought up in the discussion.
Get the colectomy.
Yeah.
Get the colectomy.
Basically, whatever lets him get
everyone.
the treatment that he needs. But
It was
yeah.
going to save him from the melanoma.
Okay.
So not even IBD in remission.
He still has IBD,
It
right?
counts, but he still has IBD.
Yeah.
Well, he still
Yes,
has IBD
he
once
still
you
has-
remove the colon too,
Yeah,
technically.
but even
I
if
mean,
he's in remission.
But they would
still
consider
wouldn't
it as no longer having UC if he had a colectomy.
Right.
Correct. Yes.
So
interesting.
thank goodness it's not Crohn's colitis.
Yes.
I didn't know that too. but, yeah.
Fascinating.
Let me pose this question to the surgeon, Dr. Pleitz, and I'm not sure if Dr. Greenstein is here.
Dr. Hahn
Dr.
is.
Hahn is.
Dr.
so
Hahn
let's-
is here. So Either one of you or
Yeah,
both of you.
I was about to jump in. Yeah, one of the issues obviously is like if this patient has metastatic melanoma and it wasn't responding, and you're trying to get on another treatment so it does respond, doing surgery is going to delay any treatment for probably months.
That's a great point. Yeah.
So because they have to recover from the surgery beforehand. So that's kind of that's the thing that kind of puts you between a rock and a hard place. That you're trying to get the we wouldn't necessarily be opposed to doing a surgery if it requires them to get the treatment they truly need.
Mm-hmm.
But if they can do the treatment without it and get the treatment started, the last thing we'd want is for the metastatic melanoma to spread further and become even worse because we did a colectomy that's mostly prophylactic.
Perfect.
Well, I mean, this is Suhan. I'm just interjecting. I kind of disagree with that. I would say if the patient is exhausting all other malignant melanoma medications, and the colectomy is the only thing that's really preventing him, and they're really drawing a hard line on not allowing them to be on the medication due to UC or IBD, I would argue, I mean, this is a discussion obviously that has to be had with the patient to an extensive degree, but I mean, I don't think you have to wait months afterwards. I mean, even within 3 to 4 weeks after the colectomy, they can start. It'll be on the riskier side of things, but I think in the urgency of time back on the medications and treatment, I would have a strong discussion with the patient.
That's
But my
good.
understanding was that one of the medication they were trying to do, maybe I misunderstood this, I thought the medication they were trying to do duotherapy on was an option, but there was another medication that they were be excluded from.
So clinical trials he would be excluded from. But the combo
Okay.
medication he can do whether or not he had a colectomy, but they were worried about the risk of ICI colitis. So that's why they thought taking the colon out would be safer.
Very got it.
Do we know about the risk of ICI colitis depending on remitted IBD versus active IBD? I mean, I would assume that it's, but is it equally high?
I don't remember the details, but from my understanding is that better controlled IBD going into immunotherapy resulted in less, but I don't know the actual numbers.
And because
So
it's a good
better control is better. Are the ONC team refusing? No.
No.
It
Yeah,
sounds
they're
like it
not.
was only if the clinical trials.
They were okay
got
doing it, but there were more of a discussion of it could be safer if we do the colectomy, but we can offer both. All right, so
But the
Yeah, in that
consensus
case,
would
then
be
I would
switch.
agree with the previous, I don't know, I forgot who said this, but in terms of checking Calpros and just monitoring, if because it is a hard sell if there's other medications available.
So what I'm hearing is based on this situation, probably a colectomy is not the right thing for this patient, but we definitely think about it if it was someone else who had higher risk, who was not eligible for medications they wouldn't offer, then a colectomy could be offered. So since it's not an area that we have a lot of data on, I think it will be kind of personalized to each patient and their risk factors.
I think, the point is all of us would probably switch off infliximab to a different
It's a
medication.
different medication. Okay. And then I think we brushed on this, but would the presence of pre-existing UC influence your decision on using combo? Anyone thinks that they would?
I mean, I think I see it sort of similar to what I say with people on aspirin or blood thinners. We will try to manage the UC, but in the meantime, they should be on whatever they need for their cancer therapy.
Yeah.
And then you try to manage the UC through it. It's always a fine line of if it's going to flare their UC and they're going to have to stop all the medications, then it's not ideal for the patient. But if it's sort of thought to be the best option for them, then do your best to
Would
control the
support it.
UC.
So the cancer at this point triumphs
Yeah.
the UC.
Agree. The cancer I mean, he's got malignant melanoma. It's malignant melanoma.
Metastatic.
It's
melanoma,
metastatic already.
Exactly.
Okay, that's the priority.
All right. And then I think we answered this. Would you continue infliximab in this patient or switch to IBD therapy? And what I'm getting a sense is all of you would like to switch, either stop or switch to something else, correct?
Get him off infliximab.
Get him off infliximab. All right, perfect. And let's say he developed ICI colitis on the combination therapy. How would you approach?
Yeah, so in Europe we do different things. We usually start with prednisone, but we have also a couple of cases now where we've started vedolizumab. Just not only just after they developed it, but Also a couple of cases where we do it up front. So we do the combination of, we consider like a high risk. We actually started a couple of patients, we started with vedolizumab up front.
So he would be a great candidate to do vedolizumab ahead of time to prevent as well,
Mhm.
since he might be a higher risk of developing ICI.
Agree.
All right. So infliximab was actually discontinued, and he was started on vedolizumab. He had a PET scan in August, which unfortunately showed progression of melanoma. So the plan was to add epi given his disease progression. They had a full discussion with the patient about colectomy. He opted out. He didn't think that he would buy into it if it was prophylactic, but if things got worse, he was open to the idea of colectomy. So he was referred to surgery. He opted out. A repeat scan in September, just before starting epi, showed dramatic tumor response. So he never got the combo.
Just started
But-
responding.
Great. Good job.
So he was continued on novo monotherapy until June of 2024, and he's currently off therapy and remains in complete response. And actually, his last dose was a year ago to this day.
And his UC is in remission still?
His UC is in remission. He had a...
Or one other.
So
Hi,
what?
I'm ready. Let's see if Mom is ready.
Did anybody anybody get stool samples anytime throughout this for microbiome stuff? I'm just wondering. I'm still interested.
I don't think so. I didn't see if he did.
Okay.
He had a colonoscopy after
He
he
did.
was switched. While he was on mono Nivo, and he was in remission.
Yeah.
Can you remind me the timing of when the nivolumab was started
So the
and then
nivolumab-
infliximab was stopped?
Yes.
And the response?
Yes, the nivolumab was started in June, and the infliximab was stopped in July. So a month later, when he didn't respond, they stopped the infliximab, and then started Veto.
So June to July, he was
on Veto.
He was, but he was on.
He was
the
on the infliximab,
infliximab
sorry,
and
Nivo.
the Nivo.
Correct.
And
yes.
no
And he
response,
saw
in fact,
progression.
worsening.
And then from 8 to, and then Veto for the next month, and then
Correct.
To try to respond.
like how long? I guess this is something for the oncologist. Like how they, I guess you see response right away normally. Like this delayed response. Let's just ignore that we switched his IBD medication. If there was no IBD medication switch in between, this would be very unusual to see progression and then response, like in that
So,
time frame. I guess that's my question, like
I
how
had
long?
the same exact question when I was looking at it, and it's not uncommon to have pseudo-progression.
Yeah, that's what I
initially,
thought,
right?
because you get increased inflammation. So that this is, yeah.
This is my patient.
Oh, okay. So yeah, I was,
think.
Yes, it's your
Okay.
patient.
so, yeah, that was my question of what do they mean by progression on that repeat scan? Because what can happen, at least from my understanding, sometimes I don't know the imaging, but in these immune checkpoint inhibitors, you get almost an increase looking of inflammation before you get resolution of the metastases, because you've got an influx of immune cells, because now you've like released the immune system against the tumors. So they light up even more before they go away.
You're absolutely correct, and sometimes patients do get pseudoprogression. And when I was looking at their notes, it seems like they did not think that's what's happening. I think they had.
I assume they didn't, but
yeah,
I'm like,
he had
how?
new sites,
Okay.
so probably that
had
came into
progression.
place.
Yeah.
Progression.
Yeah.
But
So
it
they-
also makes me wonder, because one of
It
the
makes me
things
wonder.
Exactly, right? It's interesting that he responded like at least 2 months after he stopped the infliximab. So probably the infliximab was dampening the immune therapy. So probably the first scan that he got, he had true progression. The second scan was maybe pseudo-progression in the sense that infliximab is going away, or he still had some drug effect from the infliximab. I don't think we're ever gonna know, but I don't know if anyone has any other different thoughts on.
No, I mean, since I treated him, I mean, the decision making was around desperation, really, because he had progression of already metastatic melanoma, despite best available immunotherapy. So the only thing we could do, and we felt very comfortable doing this, because he had been scoped repeatedly over many years and had no inflammation, was to simply switch him to vedolizumab, which in theory wouldn't dampen the immune response generated by immunotherapy.
So my question is, and this is sort of, I mean, in this case, I think we all thought before, we were all saying to switch him off of infliximab, but do you ever prophylactically switch them to Veto? Let's say do you just switch them at diagnosis to something like vedolizumab if they've never been on it, and not wait for them to not respond to immunotherapy?
Well, the first thing is, when you have a patient who develops a melanoma while they're on an anti-TNF, we think, oh my gosh,
Yes.
this could be from the anti-TNF,
Exactly.
and we should stop it immediately. But if you talk to the oncologist, they're like, no, if he needs it, just continue it. And so that is kind of what we did at first,
Yeah.
but and in other cases, we've sort of continued
Yeah.
right through it.
And it's interesting that we worry also about the anti-TNF in melanoma, but then when patients who have melanoma who don't have IBD get immune checkpoint inhibitor colitis, we're comfortable using the infliximab as well at that setting, right?
And there isn't
Well-
great data, I mean, at least as far as I've seen, that TNF versus Veto in that setting changes the outcome significantly.
But
it's
also
different.
it's usually short-term
Yes,
therapy.
I was going to say it's different setting. It's
It's
short
1 or 2
term versus
doses.
long term.
Yeah.
So
And usually we're not even the ones prescribing it, they are.
All right, so I guess we can move on to the second case.
I'm sorry to ruin the girl power panel.
You can be honorary today.
Thanks.
You had a question.
Now, if he developed ICI colitis non-responsive to steroids and had been on Remicade before, and then we transitioned over to Entyvio and still sort of had this ICI, that you were thinking of adding a biologic at that point, would there be a sense of what you would do in that situation, since the two most studied biologics for ICI colitis are potentially off the table?
I think you'd have to talk about whether you would go back to Remicade
Yeah.
for a short while and hope that it would work and not reverse things otherwise.
And maybe colectomy would be
then colectomy
more
might be.
of
Well, so yeah, that at the beginning of his diagnosis, that was also a conversation. You sometimes hear this. We're so afraid that patient is going, you don't hear this as much anymore. The patient has IBD. We're so afraid they're going to have terrible flare. Maybe we should do prophylactic colectomy. We heard that in the early days of immune checkpoint inhibitors, but that hasn't been the conversation any time recently.
all right. Well,
For future patients, I mean, how worried would you be if there's going to start, that your current therapy is going to dampen immune response in a way that's going to inhibit their response to the checkpoint inhibitor?
This one anecdotal patient has
Yeah.
sort of changed my thinking quite
Yeah.
a bit, and I really would consider a switch, especially a very stable patient,
Yeah.
who has documented deep healing, everything endoscopically, microscopically, pathologically, everything is under complete control. That's the best scenario to make a switch.
Yep.
And to Ali's point, also his disease wasn't severe to begin with. This was his first medication. He has left-sided UC, so really no great risk factors as well since he's in deep remission.